I'm a pre-hospital emergency medicine and critical care retrieval. I have 22 years EMS experience, and I want to encourage you also to use telemedicine.
Jesus faces was swelling like a balloon. He's also got sort of right upper body pain. Again, I just tied to the line. I didn't do it for the body. I scooped around with him. It's just this girl that's very unstable, very high airway pressure, it's difficult to ventilate. I'd say we need to get pretty much all these sort of ICU guys in, and there's three bad patients.
So Medical Cork is the HSC's national 24-hour emergency telemedical support unit, and we receive a number of calls via state agencies through either, from recently, the Tetra or our telephone networks. And with the new system we have just installed, we're able to bring additional specialist advice into the interaction. For example, from one of our famous physicians, perhaps a hyperbaric unit in Galway, even the National Medical Director, we could bring them into the call quite seamlessly if we needed to. The problem is that telemedicine suffers from an image problem. The perception is that we're there just for oversight. And that really doesn't fit well into our EMS system with sort of autonomous practitioners and the way that our system is structured. So whilst pre-alert is quite ingrained in our system, calling to simply bounce an idea off a colleague, it's really still not part of culture here.
This is Houston. Say again, please.
Houston, we have a problem. We have a main bus being underbowled. We've got a lot of resurrections here in Houston. Just went offline. Oh, there's another master alarm, Houston.
I'm checking the clock.
There's no refresh that.
Maybe it's quads.
We've got a computer restart.
I'm ready to figure the RCS.
We've got a baseline environment. We've got multiple positive warnings, Houston. We've got a restart.
All right, I'm going to SDS.
Now, for all my colleagues out there, hands up who's not had a hashtag MyEMS day that's felt a little bit like that. Okay, if you haven't, you clearly not had enough patient contact. See, when the shit's hitting the fan, do you want to debate about it? All right? Or do you want to pick up your Tetra or your radio and press talk? Both tools have their merits and both have different contexts, but every patient deserves, and we've heard about this all day today, a pre-hospital practitioner with situational awareness of their CRM limitations, who's cognitive at all those tools in the toolbox. And telemedicine is just one of those useful tools. It opens up a wealth of possibilities. We capture in Medical Corp where real problems are for real practitioners in real situations with real patients. Essentially, we capture where CPGs stop offering the complete solution. We constantly record and audit all of our interactions, and we have a healthy database now of more than 1,000 interactions. And we hopefully now are able to feed that back into the system and talk about where things go on. For example, we have 974 calls logged from advanced paramedics in just over 2.5 years. And one of the biggies is agitated patient management. I'm sure you all agree, and many of you here in this room have called us for support. And it's a pretty harrowing situation. Last week alone, I was dispatched to 2 separate rural patients, both with head injuries. There's only one thing worse than a violently distressed, actively fighting, head-injured farmer in a cattle shed with arms the size of my thighs. And that's a head-injured biker with a fear of flying. Now, neuroprotection and prevention of secondary brain injury must start early. We know about this, but how as a system do we empower our practitioners, and this is the key, to safely achieve a controlled working environment and enable neuroprotective strategies early? To me, it's all about pain management.
Very still. Hey, look at me. Henry, put this inside your mouth. All right? Do not chew it.
Enhancing care in austere environments, enabling advanced levels of analgesia and helping make those difficult decisions in adverse environments offers by far the greatest scope for telemedicine development in Ireland. We currently are polishing an SLA with the mountain rescue team here in Kerry, in Killarney, and we're sowing the seeds on land to enable essentially non-medical rescuers to develop opiate-based and deliver safely opiate-based analgesia through exactly the same legal framework that we've been enabling our fishermen for the past 13 years. It's vitally important we get this right. Telemedicine allows practitioners to be inventive in solving their daily problems. For example, since the intranasal fentanyl in kids CPG was rolled out, we virtually daily calls regarding its uses. Can we use this in adults who, for example, are trapped and they can't get IV access, just to enable the difficult splinting, so once they're splintered, they're not in pain anymore. Telemedicine gives us unique perspectives in how practitioners themselves interpret CPGs and how they themselves understand pain management. For example, APs repeatedly are asking us if they can administer more than 16 milligrams of morphine. But when you look at those cases, the advice given, in 1/3 of those cases, paracetamol and Nurofen were not added. That said, look, gut absorption is poor in acute pains. We really need something that we can deliver IV. We need paracetamol IV. First, it doesn't cost an arm and a leg anymore. I picked that up from Chronic Guilty Pharmacy for €6.40. Now, hands up who here is worried about IV paracetamol in a bottle, in a glass bottle? Who here is aware that we have it in plastic? These things are all here and available to us. I don't, however, believe the biggest breakthrough in pain relief and pain management is going to come from Big Pharma. We urgently need to research and teach effectively non-pharmacological options, such as irrigation, covering, reducing, traction, splinting. We have all the drugs that we need to do that in our toolbox. It's just enabling practitioners to be able to do things properly. Astronauts, just like our EMS personnel, are highly skilled. They're trained to manage a massive range of challenges. The core, the absolute need-to-know, bold-faced stuff you need to be able to do. Thereafter, they share the problem amongst themselves in peers based on mission control. And that's where I see telemedicine and trauma going in Ireland. Sharing the problems in a properly integrated solutions system. A bit like Romania. I believe the future in telemedicine in Ireland needs to look a little bit like Romania, where our colleagues such as Raed Arafat absolutely revolutionize the transmission of live video data, live medical parameters, using existing Vodafone infrastructure. And more importantly, they link this technology to a nationwide system with 8 HEMS-based primary critical care retrieval teams. We enable a truly national major trauma network. Trauma is a team game. Faced with a challenge in hospital, there's plenty of colleagues who offer support and opinions to guide your patient care. But patients will challenge you, they do challenge us too. We have a long way to go in telemedicine in Ireland, but the infrastructure is there and we're slowly starting to get it right. I'm a pre-hospital emergency medicine and critical care retrieval physician, and I use telemedicine.